Hi everyone, it's Hunter Hicks. Today we're going to look at some neuro disorders of the infant. So as the infant is developing in utero, we have something called the neural tube. The neural tube eventually is what we now know as the central nervous system. So it helps develop parts of the brain and the spinal cord. Well, when we have neurotubular defects, we usually have an issue where the neural tube is unable to close. Therefore, we have an opening which allows contents of the central nervous system to protrude through. One of the most common protruding things we see is spina bifida. This disease allows different portions or parts of the central nervous system to protrude through. One of the most common types of spina bifida is myelomeningocele, which is when we're protruding both the spinal cord and its meninges through an opening in the spine. With this, there's usually a little bit of skin to cover this area, but sometimes there's no skin at all. Obviously, these patients are at high risk for infection and trauma. Something we can see with these patients that are very high risk are patients with Arnold-Chiari malformation type 2. In this, contents of the brain actually protrude down through the foramen magnum. Now, one of the biggest risk factors we know that cause the spina bifida is low folate levels. This might be from decreased intake of the pregnant woman during pregnancy. Now, we don't see as much spina bifida as we used to because of a lot of our prenatal vitamins having much more folate in them, which is why it's essential that the pregnant woman is taking in a lot of folate. Other things we can find high in folate are leafy green vegetables. Now, another derangement we can see is cerebral palsy. This is usually caused by abnormal development of the central nervous system or possibly damage to it either during birth or right after birth. These patients have two different types of cerebral palsy. The most common, spastic, they'll usually have rigidity, hyperreflexia, clonus, and they might have primitive reflexes past the normal time, like the Moro or startle reflex. Outside of that, we have dyskinetic and ataxic, which have the symptoms as you can see here. Now, outside of that, there's a lot of other things we have with these patients. They have a high risk for seizure, and up to 50% of them do develop it. Intellectual delay might be a possibility. Bowel, bladder, swallowing, and speech difficulties also are things we can see here. Now, treatment for this is obviously multidisciplinary, meaning we might have physical therapists, speech pathologists, neurologists, many people helping these patients out. Some of the common medication we might see given to these patients are antispastic medications like baclofen, which increase the neurotransmitter GABA to help decrease those spasms. PKU is a metabolic disorder. In this disorder, the patient cannot convert this amino acid, phenylalanine, into tyrosine. Tyrosine is essential for neurotransmitter development in the central nervous system. The possibility or reason for PKU is these patients lack the enzyme phenylalanine hydroxylase. Again, that is what is needed to convert this amino acid into tyrosine. Well, what happens is their phenylalanine actually increases to toxic levels in the brain and blood and causes signs and symptoms like developmental delay and seizures. Now, the cause of this is usually an autosomal recessive trait. Testing for it is usually done at birth, where we test the patient for PKU. We do this by checking tyrosine levels. If they're very low, we worry about PKU. As far as treatment, we usually do a low phenylalanine diet for the rest. Next is Tay Sachs disease, which is a storage disease where the patient is unable to metabolize lipids or fatty acids. These then fatty acids accumulate at very toxic levels. Causes of this are autosomal recessive disorder, and it's also found sometimes highly in the Jewish community. Symptoms are decreased muscle tone, seizures, and unfortunately we can see death as early as 4 to 5 years. Now, some things we can do is genetic testing to look at parents that might pass this on to children, and also serum tests to see how large their lipids are and stuff like that. Now, in general, treatment is supportive because we know this is usually going to cause death pretty early on, and then we can look at genetic counseling for the parents that are at risk for their child of having Tay Sachs disease. Last but not least, we're going to talk about epilepsy. Now, epilepsy is very common in the patients under 2 years old or over 65 years old. Epilepsy primarily can just be from genetics. However, secondary can be from maybe a CNS infection, issues during birth, and it can be linked to autism. Sometimes we have no idea what causes the epilepsy. Epilepsy is usually defined as 2 unprovoked seizures in a 24-hour period. Now, we know epilepsy or seizures in general is this abnormal release of excitatory activity of the brain. It might also come from this imbalance of our GABA and our glutamate. Now, in general, we think of epilepsy in adults as this common tonic, clonic, or grand mal seizure, which we can see objectively. However, this is not common to see in under 2 years of age. The reason for this is the cranial nervous system or the central nervous system is immature in infants under 2 years. So where you see more of these focal partial seizures or spasm, right? We're not usually going to see this huge tonic, clonic seizures in our babies that we're used to seeing in the general population. And that really, like I said, is due to the immature of the central nervous system because our neurotransmitters really can't pass those hyperexcitatory signals all throughout the brain that fast to maybe cause those signs and symptoms that we're used to. Now, some of the common ones you can see are down here. Absence seizures we usually see in infants or children 4 to 10 years of age. Now, genetic cause is huge here, and what we're usually going to see is they get this impairment of consciousness, sometimes called daydreaming, where they're just staring, and then they might get eye fluttering. This can also be brought on when a patient hyperventilates. Febrile seizures are a very, very common seizure to see in any kids 3 to 5 months old. We have simple and complex. Simple, usually there's some degree of upper respiratory infection, and that seizure occurs in the first 24 hours of sickness. Now, they usually are quick, meaning they're lasting less than 15 minutes, and there's really no other big central nervous system infection involved here. Complex, we have more than one seizure, usually in a 24-hour period that the parent tells us about. They're lasting longer than 15 minutes, and there's a slight chance that it might lead to epilepsy in the complex febrile seizure. Infantile seizures or infantile spasm are a very hard seizures sometimes for parents to see because these infantile spasms, usually idiopathic or from a CNS infection, are very subtle. A lot of times they're mistaken for the startle or Moro reflex, and usually what you see is the patient kind of bring their arms out and then bring them back to their side. But they might just be kind of subtle like this. Sometimes the eyes will have upward deviation, or something. It's sometimes as simple as just head bobbing like this. There's many videos you guys should watch if you want to look to see what you should spot. A lot of times these seizures happen in clusters, so there's multiple of them a day. Something to watch out for and keeping your eyes out because, like I said, very, very subtle and often mistaken for other things. Last but not least, we have Lennox-Gastaut syndrome. Sorry, there should be an X there. Now, this is common to see in children 1 to 8 years of age. Sometimes it's a birth issue, it's genetic, and it's very common to see with our tonic seizures. Again, these are just some examples of epilepsy seizures. There's many more that I did not cover today. If you have any questions, leave a comment, and I'll see you next time.